Hi everyone, Happy New Year and welcome back to the RadioGraphics podcast. I am Cherie Wang. Please excuse my voice for this episode. We have been sick for a few weeks after my child started preschool. On that note, I hope a healthy and prosperous 2023 to all of our listeners. Today I'll be discussing the paper titled Physician Burnout versus Moral Injury and the importance of distinguishing them. This is definitely a topic near and dear to many of us, especially given the impact the pandemic has had and continue to have on healthcare workers. Good food for thought for the new year. Later on in this episode, Dr. Jonathan Revels will be discussing the paper titled Imaging of Immune Checkpoint Inhibitor Immunotherapy for Non-Small Cell Lung Cancer. As radiologists, I'm sure we can all agree that words matter and we must use the most accurate term when we are describing something. I personally believe that the words and terms we use can impact on how we feel and think about things, which in turn leads to some sort of action that addresses a problem effectively. This showcases the importance of this article, which distinguishes the two very similar yet very different terms, which are burnout and moral injury. Firstly, the definition of each term is important. Burnout has been defined as a pattern of exhaustion, cynicism, and decreased productivity. Other additions to this include anxiety, cognitive impairment, and diminished functional capacity. Now, let's contrast this with the definition of moral injury. Moral injury has been described as a deep soul wound that pierces a person's identity, sense of morality, and relationship to society. In essence, moral injury is an irreparable trauma that violates one's personal ethical standards. The ethical standards which have been instilled in us as physicians. This can lead us to question ourselves. Are we still moral beings? The additional layer that complicates this psychologically is that many of these ethical standards which are violated are thought or previously thought to be impenetrable. There is an element that we are forced to behave in a manner that is contrary to our own moral beliefs. This in turn becomes a sense of betrayal to those experiencing moral injury. From the definitions, we can see that the two concepts are actually very different and should not be used interchangeably. Because of this, the causes, consequences, and subsequent solutions for burnout will be very different from that of moral injury. So with these concepts in mind, let's explore the causes of burnout and moral injury. Causes of burnout include poor work-life balance, excessive bureaucracy, overburdening administration, and uncertainty of expectations. In contrast, the causes of moral injury include perpetrating, failing to prevent, bearing witness to, or learning about acts that transgress deeply held moral beliefs. It is of note here that the first description of moral injury was in the context of soldiers returning from the Vietnam War, with symptoms that loosely fit a diagnosis of post-traumatic stress disorder, PTSD, but did not respond to the standard PTSD treatment, and also had symptoms that were outside the PTSD constellation. The importance at that time is to understand and differentiate between moral injury and PTSD, as moral injury was a different category of psychological injury that required a different treatment. Similarly, what is important now is to differentiate between moral injury and burnout, as these require different treatment and solutions. Because of the fundamental difference between burnout and moral injury, the consequences and solutions are different. The consequences of burnout include depression, stress, increased risk of substance abuse, poor self-image, and lack of motivation. There is also decreased productivity, poor employee retention and recruitment, as well as the loss of reputation for the institution. There are obviously more consequences downstream from these. In the case of burnout, corrective measures are available for these people. Thus, burnout is generally reversible when the causes are addressed. This is contrast starkly with moral injury, where it is generally irreversible. Physicians are by and large very resilient and used to great psychological and physical stress. Therefore, to call moral injury as a mere cause of burnout is wrong. This isolates and insinuates that the physician is weak and cannot cope with the demands of their career and medicine. The most grievous consequences of moral injury are the loss of institutional loyalty, or worse, the loss of loyalty to medicine in general, and the detachment from the noble idea and the moral grounds that attracted one to medicine in the first place. Corrective measures such as changing jobs, increasing vacation time or salary may mitigate burnout, but cannot heal the permanent wounds of moral injury. When we look at moral injury in the context of medicine, there are two main culprits. The first one is a divergence of purpose between the institution and physicians, and includes imposing doctrines and ideologies that are often contrary or irrelevant to those held by the caregivers. These doctrines and ideologies can be social, cultural, or political in nature. In the setting of academic medicine, there is a tripartite mission, which includes patient care, teaching, and research. The triple mission has been increasingly superseded by institutional priorities that focuses on control of the production and distribution of medicine and the redistribution of its financial productivity. And this takes away from the original triple mission objectives of academic medicine. Let's see how we can illustrate this point. For physicians, work satisfaction is derived from their interactions with their patients and seated in how they have helped their patients. This may also be how a physician measures their worth as a human being. Are they able to deliver effective quality healthcare? And this work satisfaction, no matter the degree of labor or financial reward, is faithfully dependent on the quality of the final product. That is, in this case, patient-physician interactions. Now, the institution's priorities are divergent from that of the physician's work satisfaction framework and are nearly exclusively derived from financial considerations. There is then a tendency to pursue a business culture at the expense of medicine's human and altruistic nature. Examples of these include countless metrics of dubious relevance, data-heavy questionnaires of unproven utility, social-political activism that only improves optics, time-consuming mandatory training courses for the sake of risk management, and many other creatively myopic efforts detract from medicine's true calling. There are even punitive measures against physicians who rebel against these measures. To avoid a losing conflict, physicians impose self-censorship, settle on a daily routine of doing the minimum required to get by, or simply just resign. It has been instilled by the very same institutions that the primary moral creed of the physician is to serve the suffering patient and their psyche. This final blow is a deep betrayal. The second main culprit in contributing to moral injury is that of a compulsive bureaucracy. Compulsive bureaucracy is imposing a burdensome bureaucratic machinery that prioritizes billing, collections, risk management, and politics over patient-physician interactions. Whether bureaucracy is seen as good or bad depends on which viewpoint you want to take. However, it is undeniable that bureaucracy is not only inevitable, but necessary. But whether bureaucracy is serving the system or the public, the patient or the physician, is something to think about. Healthcare bureaucracy has indeed grown. Between 1975 and 2010, the number of physicians in the United States grew by 150%, whereas the number of healthcare administrations grew by 3,200%. In 2019, the United States spent nearly $1 trillion on administration. Now, the total cost of national health expenditures was $3.8 trillion. The Massachusetts Health Policy Commission was charged in 2019 with monitoring healthcare spending growth and providing data-driven policy recommendations regarding healthcare delivery. Its principal recommendation was to take action to identify and address areas of administrative complexity that adds cost to the healthcare system without improving the value or accessibility of care. So, how is bureaucracy a potential cause of moral injury? In its final transformation, the inner machinery of bureaucracy becomes cryptic and its boundaries become impenetrable to those it is supposed to serve. The system underpins the gradual transfer of power from those who deliver healthcare, which are the physicians, to those who administer it, which are the bureaucrats. It protectively isolates the bureaucrats from the direct reach of physicians until finally it transforms physicians into bank tellers, policed by an impersonal, confusingly structured, and unapproachable bureaucratic machinery. There is, however, several causes that are common between burnout and moral injury. Perhaps because these two concepts represent a continuum. These causes include detailed, excessive administrative burdens and cumbersome electronic health records. So now that we know the difference between the two, what can we do to prevent or mitigate moral injury? We should realign priorities. The institution should educate administrators in regards to the ethos of patient care. Administrative machinery should work to facilitate physician clinical practice and not become a conduit of it. The administrative hierarchy should function as much as possible within an administrative structure with the aim of making clinical practice efficient, effective, and patient-centered. It should not regress into bureaumania, where bureaucracy insinuates itself between the physician and the patient through regulating, policing, and obstructing effective delivery of healthcare to achieve the primary goal of self-preservation. Resources should also be redirected from bureaucratic efforts of little value towards improving healthcare quality and accessibility. Those who deliver healthcare should also be shielded from unnecessary tasks. Bureaucrats should also be exposed to daily clinical experiences and see how it is affected by bureaucratic tasks. Lastly, I leave you with this striking paragraph from the authors. Do not confuse moral injury with burnout. They are strikingly different concepts with different causes and consequences. A crucial point is that, in general, moral injury tends to be permanent, and the timing of any mitigation intervention should be when signs of burnout are evident. Accusing physicians who are morally injured of being burnt out is the equivalent of labeling shell-shocked soldiers who are returning from war as cowards.
Imaging of immune checkpoint inhibitor immunotherapy for non-small cell lung cancer. In this review, Dr. Schroff and colleagues do a fantastic job summarizing the basic principles of immune checkpoint inhibitors, including mechanisms, indications, response assessment, and spectrum of immune-related adverse events. I will focus on the background of these medications and their use in cases of non-small cell lung cancer, how we evaluate disease response, and some of the immune-related adverse events as they pertain to the chest, abdomen, and pelvis. The authors created some really awesome tables, figures, and case examples for this article, and I encourage all of you to go check it out when you have a chance. The normal immune system has three primary roles in the prevention of cancer: protecting the host from virus-induced tumors by eliminating or suppressing viral infections, preventing the development of a tumorigenic environment by means of timely elimination of pathogens and prompt resolution of inflammation, and lastly, identifying and eliminating cancerous and precancerous cells. Unfortunately, tumors can develop immune resistant mechanisms, including the exploitation of the immune checkpoint pathways, which are inhibitory pathways that normally suppress T cell function to prevent autoimmune reactions. Immune checkpoint inhibitor medications help to prevent tumors from exploiting these pathways. The immune checkpoint molecules that have been studied the most in terms of cancer immunotherapy are cytotoxic T lymphocyte associated antigen 4, CTLA4, programmed cell death protein 1, PD1, and programmed cell death ligand 1, PDL1. Some examples of the immune checkpoint inhibitor medications and their associated molecules include the CTLA4 inhibitor ipilimumab, PD1 inhibitor nivolumab and pembrolizumab, and the PDL1 inhibitor durvalumab. Today, most patients with metastatic non-small cell lung cancer receive anti-PD1 or anti-PDL1 immunotherapy with or without chemotherapy or anti-CLA4 therapy in the first-line setting. This is because studies have demonstrated a statistically significant improvement in overall survival of these patients with use of PD1 and PDL1 inhibitors when compared to platinum refractory advanced non-small cell lung cancer. In fact, the National Comprehensive Cancer Network recommends testing for PDL1 expression in all patients with metastatic non-small cell lung cancer to determine whether immune checkpoint inhibitor regimens are an option. Let's talk about response assessment. Early clinical experience with immunotherapeutic agents showed that traditional response criteria, such as the World Health Organization criteria or the initial response evaluation criteria in solid tumors, RESIST, were not sufficient to fully characterize activity in patients receiving immunotherapy. There are a few reasons for this, including immunotherapy can take longer to show measurable anti-tumor activity, responses to immunotherapy may occur after the identification of progressive disease, such as development of new, small lesions in the presence of other responsive lesions, and prolonged stable disease may represent anti-tumor activity. As a result, modified response criteria termed immune-related response criteria, IIRC, were developed with two key modifications from earlier criteria. First, IIRC required confirmation of progressive disease on 2 consecutive studies at least 4 weeks apart, rather than declaring progressive disease at the initial increase in tumor burden in order to address pseudoprogression, which I will discuss shortly. Second, IIRC include the measurements of new lesions in the sum of the total tumor burden for response assessment, rather than defining progressive disease. The authors include a succinct summary table for tumor response criteria in the article, which covers RESIST 1.1, IIRC, IR-RESIST, and iRESIST, which again I encourage you all to go check out when you have time. Let's circle back to pseudoprogression. Pseudoprogression is rare, with an estimated incidence of 4% across various cancers. It represents an atypical response pattern whereby patients initially show progressive disease after initiation of immunotherapy, but subsequently show reduced tumor burden on follow-up studies. In this regard, the increase in tumor size and new lesions are factored into the total tumor burden and considered unconfirmed progressive disease, and the immunotherapy is continued until progressive disease is confirmed at the follow-up imaging, which again should be performed at least 4 weeks later. Hyperprogression is another rare pattern described with immunotherapy and refers to a dramatic increase in tumor burden early after the initiation of immunotherapy. Currently, there is no standard metric to determine hyperprogression, and the concept is controversial since it is not possible to determine whether the acceleration of tumor growth is induced by immunotherapy or simply reflects the natural course of the cancer. Now let's talk about immune-related adverse events, IRAEs. And again, I'm going to focus on the entities that pertain to the chest, abdomen, and pelvis. Since immunotherapy activates the immune system, These medications can lead to inflammatory side effects, which are called IRAEs. IRAEs can affect many organs, including the lungs, heart, gastrointestinal system, and endocrine system. Patients with IRAEs can have variable presentations, ranging from no symptoms at all to life threatening conditions such as shock. The reported incidence of IRAEs in patients with non small cell lung cancer ranges between 30 to 66%. IRAEs can manifest within weeks to months after initiation of immunotherapy, and they can even manifest after termination of therapy. Interestingly, some studies of non small cell lung cancer and other tumors have shown that patients who develop IRAEs have superior progression free and overall survival compared to patients who do not develop IRAEs. Treatment of IRAEs is aimed at reducing the state of excessive inflammation through use of glucocorticoids and, if necessary, suspending or discontinuing immunotherapy. Pulmonary IRAEs include entities such as pneumonitis and sarcoid-like reactions. Immune checkpoint inhibitor-related pneumonitis is a serious IRAE, and patients may present with cough, dyspnea, and hypoxia, in addition to the imaging abnormalities. The median time to onset of immune checkpoint inhibitor-mediated pneumonitis following initiation of therapy is around 3 months, and some of the risk factors include tumor histology, prior or current smoking, and pre-existing interstitial lung disease. Although most of these pneumonitis cases are low grade and improve or resolve with drug withholding and or steroid therapy, mortality rates can be as high as 18% in patients with non-small cell lung cancer. The imaging features of immune checkpoint inhibitor pneumonitis can vary, but the most common appearances are ground glass opacities and an organizing pneumonia pattern. When immune checkpoint inhibitors are restarted, approximately 1/3 of patients develop recurrent pneumonitis that tends to have similar imaging patterns but more extensive involvement than the initial pneumonitis. Radiation recall pneumonitis, RRP, refers to the inflammation in previously irradiated lung after exposure to an inciting pharmacologic agent, which includes both immunotherapy and non immunotherapy medications, and it may represent a hypersensitivity drug reaction. On imaging, RRP manifests with new pulmonary ground glass and or consolidative opacities months or even years after radiation therapy that conforms to the radiation treatment site. In patients who have received both radiation therapy and immune checkpoint inhibitor therapy, differentiation between immune checkpoint inhibitor pneumonitis and radiation pneumonitis can be extremely challenging. A couple of potential clues include immune checkpoint inhibitor related pneumonitis is not typically confined to the irradiated lung, except in cases of RRP, whereas radiation pneumonitis is generally limited to the radiated lung field. Another potential thoracic manifestation of immune checkpoint inhibitors is sarcoid-like reaction, which can mimic metastatic or progressive disease. Pathologic sampling is required to identify the non-caseating granulomas and exclude disease progression. This condition can manifest as bilateral mediastinal and hilar adenopathy and bilateral upper lobe predominant peribronchovascular and perilymphatic lung nodules. When imaging findings are characteristic, the diagnosis may be suggested on imaging alone, and the oncologist may choose to follow up rather than biopsy. Cardiovascular IRAEs can involve the heart, pericardium, and vasculature. Myocarditis is the most common cardiovascular IRAE, and patient presentations can range between asymptomatic to cardiogenic shock. Up to 80% of IRAE myocarditis cases occur within 4 months after initiation of immunotherapy. The cardiac MRI features of AE myocarditis are similar to those of other causes of myocarditis, including the presence of late gadolinium enhancement and myocardial edema. Pericardial IRAEs include pericardial effusion, pericarditis, tamponade, and perimyocarditis. The median time from immunotherapy initiation to the onset of these diseases is about 30 days. In the setting of pericarditis, a pericardial effusion, pericardial thickening and or enhancement, or a combination of these findings may be seen. The most common reported immune checkpoint inhibitor related vasculitides are large vessel vasculitis, such as giant cell arteritis, and aortitis. The median time from the initiation of immune checkpoint inhibitor therapy to the onset of these vasculitides ranges between 55 days to 3 months. On imaging, the involved vessels may be narrowed and or obstructed, as well as demonstrate aneurysms or dissection. When IRAEs affect the gastrointestinal tract, patients may present with diarrhea and abdominal pain due to immune checkpoint inhibitor related enterocolitis, which is one of the most common IRAEs in general. The median time to onset of immune checkpoint inhibitor related enterocolitis can range between 5 weeks to 4 months. CT imaging in ipilimumab related colitis may show diffuse or segmental wall thickening. The primary role of imaging in these cases is to evaluate for complications such as bowel perforation, obstruction, or toxic megacolon. IRAEs can also affect the pancreas, liver, and biliary systems, resulting in pancreatitis, hepatocellular injury, and cholangitis. In cases of pancreatitis, the onset can range between 69 to 146 days, depending on the immunotherapy agent used. On imaging, the pancreas may be edematous with adjacent fat stranding, and on PET-CT, it may appear hypermetabolic. When hepatotoxicity occurs, it is usually within 1 to 3 months after initiation of immunotherapy, and on CT, the liver can have a range of appearances from normal to enlarged or demonstrate periportal edema. In patients with non-small cell lung cancer on nivolumab who experience immune checkpoint inhibitor cholangitis, the time to onset can be anywhere between 1 to 12 months, and some of the imaging manifestations include biliary ductal dilation with wall thickening and enhancement, as well as gallbladder wall thickening and periportal edema. IRAEs can affect multiple organs in a single patient simultaneously, and in cases of non-small cell lung cancer, the incidence is about 5 to 9%. Interestingly, multisystem IRAEs in patients with non-small cell lung cancer can be associated with improved overall survival and progression-free survival. Now let's recap what we've learned today. First, immune checkpoint inhibitors have truly altered the treatment paradigm for patients with non-small cell lung cancer, and these medications essentially function to prevent tumors from evading our immune system. Second, we as radiologists should be aware of the response criteria that have been developed specifically for immunotherapy cases to ensure we are conveying the correct information to our oncology specialists as to whether the disease is actually progressing. Third, because immune checkpoint inhibitors activate the immune system, they can lead to a host of adverse events termed immune-related adverse events. These immune-related adverse events can range from asymptomatic laboratory abnormalities to life-threatening conditions. Lastly, knowledge and awareness of the various immune-related adverse events is important for preventing the misinterpretation of these events as metastatic disease, progressive disease, or infection, and for facilitating appropriate and timely patient management.
I hope you all enjoyed this episode, and as always, take a look at these articles in mine. Happy New Year, and thank you for listening, and see you next time.